Chairpersons, expert panelists, and learned audience. Assalamu alaikum. I am Dr. Mohammed Shakwat, going to present on transcatheter closure of the second-term ASD tips and tricks. There has been a remarkable improvement in the treatment strategy of the second-term atrial septal defect over the last few decades. With the improvement in device technology and procedural techniques, transcatheter closure of atrial septal defect is nowadays accepted as the treatment of choice. Recent generation device with biocompatible materials enable easy and safe deployment with the properties of flexibility, recapturability, and repositioning. So, use of improved device design and refined equipment finishing promotes reendothelialization and reduces the potential damage to the nearby structure. In addition to improvement of device properties and performance, there has been a distinct improvement in the procedural technique from numerous experience of device closure of the ASD. So, ostium secondum is the most commonest septal defect among the other septal defect. So, how to assess that second-term ASD for device closure? By transthoracic echocardiography for the both pediatric patient and thin-billed adult patient, and transesophageal echography for the adult and obese child, and sometimes with the intracardiac echocardiography for the adult, but it is not available in Bangladesh. So, what is the role of echo to assess the defect? Identify the septal defect is present, defect type, number of the defect, measurement of the size of the defect and available range, and coexisting congenital cardiac abnormalities, assessment of the hemodynamic effect, assessment of the transcatheter ASD device positioning during the procedure, and assessing the post-transcatheter intervention like embolization, residual, shunt, positioning of this other structure, etc. So, rims are very important for deployment of the second-term closure of the second-term ASD. What are the rims needs to be consideration? Atrioventricular valve rims or mitral rim, and IBC rim or SBC rim, posterior rim including posterior superior or posterior inferior, retroaortic or aortic rim, superior and inferior rim, and coronary sinus rim. These are the images of retroaortic rim. This is the retroaortic rim, and this is the SBC rim. This one is SBC and this one is IBC rim. This is a posterior rim, this is a mitral rim, and this is coronary sinus rim. So, who are the acceptable device candidate? More than one device absence, probably no, if it is very important rim. Retroaortic rim absence, yes, it can be acceptable for device candidate. Posterior rim absence, probably no, but it depends on the size of the defect because it enhances the migration risk of the device. Inferior rim absence depend on the extent and coronary sinus. And superior rim absence, yes, it is acceptable, but in exception of true sinus venosus and partial anomalous venous return. For the atriomitral valve rim or absence of mitral rim depends on overall extent and proximity of the device to the mitral leaflet or tricuspid leaflet. So before going to the device closure for second-term ASD, we have to understand the device structure. There is two discs, LA disc and RA disc, and between these two discs there is a waist. Actual size of the defect or size of the device should be based on this waist of the devices. Usually RA disc is smaller than the LA disc. So what are the other ways for sizing of the defect, there is angiographic balloon angiography can be done, or for the floppy rims, stop flow technique also can be done. So this is the device with left disc and LA disc and RA disc. In between the these two discs is the waist and with the delivery cable. What are the available devices are there should be known, because this is amperature. It is started from the 4 to 40. These are other Sera rims and Sera devices or oculotech fibula flex. These are also 4 to size are also 4 to 40, but customized size are also available. So for the device selection, device size selection, device without balloon sizing 2 mm greater than the largest size of the transesophageal echocardiography size. Waist 1 to 2 mm greater than the sizing balloon diameter in stop flow diameter of the device defect of the septal defect. Waist 1 to 2 mm greater than the size of the largest size of the measured color by the transesophageal echocardiography. But in case of ring absence, or it has to be taken 2 to 4 mm more than the size of the actual defect. And LA must be able to accommodate the device. So interictal septum should be lower, not lower than the LA disc. Is the patient suitable for device closure? What are the criteria are there? Usually AHD secondum should be, diameter should be less than 34 mm, and rims except aortic rim should be, better it would be 7 mm, but at least should be 5 mm, and dimension of the septal length not smaller than the LA disc of the chosen device. And what are the poor anatomic candidate? Absence of significant posterior rim, mitral rim or IBC rim defect, because it increases the risk of device migration. So what are the common approaches for the interictal septal defect closure? That is a pulmonary venous technique, left pulmonary upper vein or right upper pulmonary vein, or LA rope technique, or wire assisted, dilator assisted or balloon assisted technique, or snare technique. If it is multiple AHD is there, so multiple AHD technique also there. It should be smaller, one should be closed first, and there is some other technique also is there on some center like transthoracic echocardiography technique also without angiography. So here is one standard approach for simple AHD closure. One 37 years old man with large AHD secondum. We have taken 24 AHD device, but it fall down, and then we upsize our size to 28, and we have successfully deployed this device. And
Dr. Alam, your time is over. Please,
sir,
we finish. Please finish your presentation. Your time is over. The slide is not showing. Please finish your presentation. Dr. Shakwat, you are not audible and your slides are not also showing.
So in conclusion, the size of the defect and adequacy of the rims and stability of the septum define the limit of the AHD device closure. Standard approach for the both simple or difficult cases help in successful transcatheter closure of the AHD secondum. Thank you so much.
Thank you, Dr. Shakwat Alum, for your very informative information. I think students are getting very benefited from this presentation. I would like to request Professor Abdul Salam sir to give some share experiences on AHD closure on us.
Thank you, Dr. Sunara, for giving me the opportunity. That is, ASD device closure is nowadays a standard procedure, and everywhere in the pediatric cardiac as well as adult cardiac center, they are practicing. So the presentation you have given is a standard presentation. It was excellent, and all the information you have enumerated. But we have to consider the simple ASD and complex ASD according to the complexity of the rims. So before going to put a device, we have to know the indication and as well as the contraindication. So we have to measure the defect in at least 3 orthogonal view. That is the long axial 4-chamber view, short axis view, and bicaval view. So the rims which are important for selection of the device is not to put or to put, that is the IBC rim. Because the device usually stands against the gravity on the IBC rim. So IBC rim interrogation is very easy by the transthoracic echo in subcostal long axial view, bicaval view. But in case of transesophageal echo, we have to go for 70-degree retroflexion. So you can visualize this IBC rim. All the rims you have already described. The posterior rim is also important. And there are multiple techniques to deploy the device. The standard technique is the LU PV approach. But in case of large defect, it is more successful in case of RU PV approach. And there are techniques as also you have described. That is the sometimes the sizing of the defect echo is sufficient, but sometimes balloon sizing is necessary when there is floppy rims as well as the.
So already we are behind time. May I request our first presenter, Dr. Mohammad Shafiqur Rahman Patwari.
এখানে হ্যাঁ এটার ভিতরেই ফোল্ডটা কপি করি হ্যাঁ হ্যাঁ আপনার কোনটা হ্যাঁ আপনার কোনটা
হ্যাঁ ডিক্লেয়ার করলাম না এই যে এটা আপনি কি কানে শুনেন না এত রেড করলেন কেন
ওইটা নিয়ে
ওটা নিয়ে করবেন কেন প্রেজেন্টেশন এত ঠিক না এটা তো না আমি যেটা দিচ্ছি ওটা কোথায় আমি এটা দিয়ে গেলাম না আবার কেন প্রিন্টার দিব
ওখান থেকে ফাংশন করা তো স্যার ওখান থেকে সব চেঞ্জ হয়ে যায়
চেঞ্জ হচ্ছে কেন আপনি তো এখানে ইয়ে করেন
স্যার আমি তো এখানে দিয়েছিলাম
হ্যাঁ আপনারা এখানে ইয়ে করলেন রাখলেন কিছুক্ষণ আগেই তো নিলেন সেটা কোথায়
ওখান থেকে অটো আসলে স্যার ইয়া হয়ে যায়
এখানে এটি ওপেন করেন এটার থেকে আমি প্রেজেন্ট করি আমি প্রেজেন্ট করি সবাই আমি তো সব রেডি করে এখন যে প্রেজেন্টেশন করার কি কই কই ওখানে আসে
যে ইয়াতে
ম্যাম কোথায়
এখানে আসলে তো
আসে না কেন
স্যার আসেন স্যার
ঠিক Honorable Chairperson, discussant and moderator of today's session. Assalamu alaikum. I am Dr. Mohammad Shafiqur Rahman Patwari, presenting today my case. History and examination of this patient reveals she is 68 years, diabetic, hypertensive, and having the paroxysmal atrial fibrillation and occasional ischemic chest pain, with history of non-ST elevated MI 4 week back. On examination, pulse is irregularly irregular with 98 per minute and normal blood pressure, and no other relevant findings is there. And patient is on rivaroxaban and rivaroxaban, clopidogrel, carbidiol, ramipril, and atorvastatin. And investigation findings reveal echocardiogram shows atrial fibrillation with anteroseptal ischemia, and echocardiogram shows anteroseptal wall is hypokinetic with ejection fraction is mildly reduced and dilated LV, no thrombus in the cardiac chamber. And other investigation reveals no remarkable findings. This is the electrocardiogram of this patient, and this is the echocardiogram of this patient. And angiogram of this patient shows there is a normal left coronary arteries and 95% stenosis in the mid part of the LED, with 90% stenosis in the osteoproximal part of the D2, with Medina 111 lesion, LCX, OM, and RCA normal. And we treat this patient, that is LAD D2 biperfusion lesion with DK crush technique. And we use the guide wire, the Lancer guide catheter. 2 floppy guide wire is used. And pre-dilatation, initial pre-dilatation done with 2 into 10 millimeter NC balloon for D2 and 2.5 into 12 NC balloon for LED. And D2 lesion is treated with 2.5 into 14 millimeter dash stent. And first KBI done, then 2.75 into 35 millimeter dash stent deployed in the LED, and final KBI and ports and good angiographic success is evident. This is the procedural, that is angiographic findings. And we found that this patient had SAT bus score is 5, that is A68, diabetic, hypertensive, non-stimulated myocardial infarction, and the patient is female. And has bleed score is 3, A68, hypertension, and concomitantly patient taking the NOAC and the antiplatelet. As guideline recommended, that is the patient, if SAT's bus score is more than or equal to 3 in women, we prepare the NOAC and so advise. As because this patient is the has bleed score is more than 3, so we use the rivaroxaban 15 milligram instead of 20 milligram OD. And patient have some high thrombotic risk for the thrombosis in the coronary arteries. That is patient having the diabetic, and his the history of non-ST elevated MI. This is bifurcation lesion, and the 2 stent implantation is there. And there is a many thrombotic risk factors there. We found these 3 factors in this for this patient. And for this reason, we prescribe the triple therapy, that is aspirin, clopidogrel, and oral anticoagulant for longer than the 1 week, that is less than 1 month, up to 1 month, as because he has the high thrombotic risk. And according to the ESC guideline, we found that if the patient have SCS with PCI, if complex lesion, we advise the NOAC for the long term, and P2YT inhibitor for the 12 month. If the high risk for bleeding, we shorten the duration to the 6 month, and aspirin up to the 1 month if the high risk of thrombosis. if less risk of thrombosis is prescribed less than 1 week. And for this reason, we advise this patient with 15 milligram rivaroxaban on the background of low aspirin and the clopidogrel. And we mentioned that is the high risk of thrombotic as because patient history of non-steroidal diabetic and anatomical or procedural factor that is bifurcation lesion with 2 stent. And we prescribe this patient for the 1 month TAT and followed by DAT for the 12 month. After 3 weeks, the patient developed ischemic hemorrhagic stroke in the right thalamoganglionic area with left-sided hemiparesis and slurred space. And this is the CT scan findings of this patient. And there is many questions in my mind. There is some social problem is there, Facebook, and there is some social media problem and legal issue also there. Whether patient can be treated with provisional stent, single stent, and can we use the less duration of the TAT. There is another risk is there is a chance of stent thrombosis. There is a new cardiac event. There is a chance of ischemic stroke as patient is atrial fibrillation, and the stroke score is 5. And there is a chance of recurrent intercalated hemorrhage also. Then how will treat this patient now? After consultation with the neurologist, we hold the rivaroxaban as aspirin and continue the clopidogrel. And on this treatment, patient is stable. After 24 hours, we do the CT scan to see whether a hemorrhagic component is increased or not, but not increasing. And guidelines say for the, that is a recommendation for stroke prevention in AF patient after intracranial hemorrhage, need consultation with the neurologist and patient clinical situation and other risk factor assessment. And there is another question is, as patient having the atrial fibrillation and his risk score for ischemic stroke is 5, so we need re-initiation of the anticoagulant in the first intracranial bleeding state. And for the re-initiation, in this time, we address some factor which increase the intracranial hemorrhage, and this factor can be modified in this time, including the hypertension and other factor not present in my patient, that is the smoking, excess alcohol intake, concomitant antiplatelet drug, anticoagulant, etc. And they recommended that if intracranial hemorrhage, there is a chance of ischemic stroke also there. For this reason, class 2A recommendation of initiation of the oral anticoagulant as far as possible. This is the time is 2 to 4 weeks. And for this reason, we try to initiate this start the anticoagulant within this period time. As because his third bus score is 5 and has bleeding is 4, that is high chance of bleeding, high chance of ischemic stroke. For this reason, after 2 weeks, with the absence of any clinical and radiological deterioration, we start rivaroxaban and repeat CT scan done after the starting of the rivaroxaban, but patient is not increasing the intracranial hemorrhage. For this reason, we discharge this patient with DAT for further 5 months. And take-home message of my presentation is, in atrial fibrillation patient undergoing complex bifurcation PCI, concomitant risks of ischemic stroke and ischemic embolism, bleeding need to be carefully balanced with considering the use and duration of the combined antithrombotic therapy. Thank you all.
Thank you, Dr. Patwari. Very nicely presentation. Any question, please?
Great presentation and a very tough case to decide about the duration of therapy. After how long did the patient develop the intracranial hemorrhage? After how many after post PCI?
After 3 weeks.
3 weeks. Okay. So could stopping the aspirin after 1 week in such a case, because the head has score. Could you consider stopping aspirin now? If you think back, what could we do so that avoid this? What can we do now? Suppose if you have a case like this, Will you change your strategy now?
Don't understand the question, please. Again.
Suppose you have this case today now again. The same patient comes back to you again. Now we are wiser with this presentation. What changes will we do so that he doesn't get a hemorrhage again? What will you try to do that he doesn't get a hemorrhage again?
If patient comes with recurrent hemorrhage,
No. Another patient with the same symptoms now. Will we do some changes in our therapy?
You had an option.
and option it depends on the duration. That means duration at procedure. Procedure থেকে duration এর উপর নির্ভর করবে. If patient comes that is hemorrhagic stroke within the first, that is 1 month. That is 1 month, it is the important period if the complex PC is there. There is TFL anticoagulant is needed. If there is a complex lesion, complex patient treated with multiple stent, and as well as patient having the atrial fibrillation, then we need the TFL anticoagulant therapy.
You have two options, either to continue or 7 days or up to 1 month. So he's asking that if you face another patient like that, will you consider to stop it within 7 days of this triple therapy? This is his question.
Yes, if we come to within 7 days, we stop the drug.
It's a very difficult question, and the answer is difficult because, we are talking about antiplatelet and anticoagulation. So we don't want to stop the anticoagulation because of atrial fibrillation, because for sure, we know these people come in with thromboembolic strokes. And the problem is giving only one antiplatelet because the patient has a bifurcation, 2 stents, is also taking a risk. So I guess, every patient is unique and every doctor will make their own decision. Maybe you would give 1 antiplatelet and 1 anticoagulation, and some would give 2 antiplatelets for 1 month, but before that he already had a hemorrhagic stroke. I think it's a very, very difficult question to answer.
Yeah, unpredictable one. Dr. Shafiq?
Yes.
Yeah. The first thing is that if we go for from the procedural perspective, your case. So in that case, you know that you are telling that he has the patient has the history of STMI, right? But how many days back?
4 weeks back.
4 weeks back. So it's not an ACS setting.
Yes, that
Now,
is history of ACS.
History of ACS, but it's not an ACS
At
setting.
this time.
So now, according to the guidelines, you are not going to follow that ACS with ACS for triple and antiplatelet therapy or anticoagulation, whatever it is. Second thing is that you have to put the patient as a CCS1 because now he has an ongoing angina or something is like that. First thing. Second thing is that from the previous history that the patient has atrial fibrillation. So patient will need anticoagulant. At the same time, patient will need dual antiplatelet therapy. So in this sort of cases, if I were there, I wanted to do that bifurcation simple.
Yes.
That is one
that
thing.
is
Because
one question in
your
my mind.
case,
It's
your
provisional.
case has a diagonal, has got stenosis, but at the same time it's not fulfilling the definition criteria. That means it's not a complex bifurcation, true bifurcation lesion. Because you know that in definition criteria, so according to definition criteria, or the DK crush 5 or Letman, whatever it is, but in definition 2 also, if it is a complex left main bifurcation, then you can think of a 2-stent strategy upfront. And it may be better with the DK crush in this part of the planet. Or you can go for culotte and other things if you go to Europe. So, for this case, you have a diagonal lesion which is less than 5 millimeter. Lesion length is less than 5 millimeter. So can easily you can predilate or you can use a drug-coated balloon for side branch and you go for the proximal to distal MB stenting, single stent. So if you go for a provisional
single is
philosophy for this case, as you know that the patient will need an anticoagulant also later, so it would be the best option for you for that patient. So you can go for a simplification of the anticoagulation and also the antiplatelet. You don't need to think that much because it's not a high thrombotic risk patient at that time. So that's the issue here. So you have to start from the procedural part also to plan that one, which case you have to plan in a simpler way to make it simple, safe, and swift, KISS principle. So, or otherwise you may face these sort of things because you don't know that when hidden thalamic or hypothalamic bleeding will happen for any patient. It may happen.
Thank you very much.
Yes, it
Thank
may
you very
be
much,
we
Dr.
reduce
Patwari.
1 stent and antiplatelet up to the 1 week.
We are running behind time.